All right. Neutrophils will be attracted and release their mediators, producing changes in the lungs. Basically, I'm talking about this stuff again, okay? Here you see it in box form. Here we see it just in words. So capillary permeability goes up. These mediators will produce destruction of substances in the lung that help hold its shape. You get little pulmonary microemboli that can form. You get little vasoconstrictions that can form. Those things produce pulmonary hypertension. The injury or the exudative phase happens 1 to 7 days after a direct lung injury or a host injury. Your neutrophils adhere to the pulmonary microcirculation. You get damage to the vascular endothelium, increased capillary permeability. Your primary pathological changes are interstitial and alveolar edema. Remember the non-cardiogenic or non-cardiac pulmonary edema, and atelectasis. 1 to 7 days, usually 24 to 48 hours, but anywhere from 1 to 7 days. Okay, we've seen this picture before. Fluid crosses into the alveolar space and you end up with an intrapulmonary shunt. Alveolar fills, and there's not enough air there for oxygen to get across. The CO2, it does a better job of getting out, but you're going to see hypoxemic respiratory failure first and foremost here. Your alveolar cells, type 1 and 2, they're damaged, and so you don't have surfactant. Allows for atelectasis to happen. And then a Highland membrane forms and it lines the alveolus. That contributes to the atelectasis and to fibrosis. The Highland membrane, that's composed of necrotic cells, protein fibrin. It lays right next to the alveolar wall, and it produces a diffusion limitation by producing fibrosis. This picture here shows you the hilar membrane. That's kind of what I wanted you to see. It forms right along the alveolar wall, and it causes that alveolus to become stiff. There's a lot in that picture, actually. The normal alveolus and the injured alveolus during the acute phase. You get a severe VQ mismatch, severe shunting. You've got all this lung that can't move air through it, can't get oxygen through it. And so the pulmonary capillaries become hypoxemic. Even though we add increasing amounts of oxygen, that shunting happens. That's the refractory part, causing refractory hypoxemia. The lungs become less compliant, and so more airway pressure has to be generated. You see more work of breathing. You see the respiratory rate goes up. As the lungs become stiffer, can't expand, the tidal volume goes down. You'll have initially for sure respiratory alkalosis because you have increase in CO2 removal because you're trying to get the O2 across. The O2 can't move across all this stuff in the lungs, this fluid, this necrotic stuff, these proteins, this stuff that's flooding the alveolus. The CO2, remember, is pretty diffusible. Eventually you end up with low cardiac output and tissue perfusion. That is the injury phase. The reparative or the proliferative phase, this happens 1 to 2 weeks after initial lung injury. I hope you're getting the idea that ARDS is a big deal and it takes a long time to get over if you survive. Now we're in the reparative or the proliferative phase, and things are still not going well. You get an influx of immune parts of the immune system, neutrophils, monocytes, lymphocytes. You get fibroblasts that proliferate. Those fibroblasts will destroy the pulmonary vessels. The lungs become very dense and fibrous, and lung compliance continues to go down, producing high blood pressure in the pulmonary system. Hypoxemia gets even worse. The alveolar membrane thickens. You've got severe diffusion limitations. You know, it's like initially the alveolar capillary membrane is permeable to everything, and then as it thickens, it's permeable to nothing. You get shunting that happens when blood goes by, but there's no oxygen to be picked up. That's shunting. If the reparative phase persists, you end up with widespread fibrosis. If this phase is arrested, then the lesions will resolve. We still have to support a patient through it. The fibrotic or the chronic late phase, this is 2 to 3 weeks after the initial lung injury. The lung will be completely remodeled by sparsely collagenous and fibrous tissues. You've got very low lung compliance because the lungs are very stiff. You have very reduced area for gas exchange. You have pulmonary hypertension from the blood vessels in the pulmonary system being constricted and destroyed and fibrotic. What I would say is that some people do survive the acute phase of lung injury. The pulmonary edema resolves and they end up with a complete recovery. However, for those who enter the fibrotic stage, survival chances are very poor and they require long-term mechanical ventilation. It's not known why injured lungs repair and recover in some patients and not in others. There seem to be factors that are important in determining course of ARDS, things like the nature of the initial injury, coexisting diseases, and pulmonary complications. You know, when a patient requires long-term mechanical ventilation, if they don't already have certain problems, they're very prone to getting them. And so much of our nursing care has got to focus on minimizing the consequences of long-term mechanical ventilation, minimizing the consequences of long-term immobility. Initially, we're back to, initially now, the presentation can kind of creep up on you. You can't quite put your finger on what's going on with this patient. They may only have some dyspnea, some shortness of breath, they may be coughing, they may be restless, something's just not right. If you listen to their lungs, you may hear fine scattered crackles, and then that progresses to fine and coarse crackles. Initially, they're mildly hypoxemic with a little bit of hypocapnia, and eventually that's going to progress to hypoxemia that is out of control and needs to be intubated. The chest x-ray, at first it might be normal, so the patient might have these insidious symptoms. They just don't look right, they're working harder to breathe, their SATs are kind of marginal, you're having to go up on the oxygen, they're getting kind of restless and confused. Chest x-ray looks okay, what in the world's going on? And then eventually you will see, within 24 hours or so, you'll see interstitial infiltrates, diffuse patchy infiltrates. The symptoms will worsen. Hypoxemia producing hypoxia and a metabolic acidosis will occur. You will see evident discomfort and work of breathing. They're using their accessory muscles. If anyone has time to do a pulmonary function test, you will see lung compliance and lung volumes are down. Tachypnea, diaphoresis, cyanosis, pallor, restlessness, confusion, tachycardia, hypotension. Those are all happening to this patient. As the ARDS progresses, they develop respiratory distress. They will require endotracheal intubation and positive pressure ventilation. The chest x-ray, we call this whiteout or white lung because of the consolidation and infiltrates throughout the lung. This is the normal lung. Same patient, and this is the ARDS. Here initially you might see just a little bit of infiltrate stuff there, but I want to say that this is 24 hours from here to here.